Health Watch is presented by UMass Memorial Healthcare. Here, caring for you.
In this segment, Tommy John surgery. What is it and who needs it?
The surgery itself is actually a reconstruction of the ulnar collateral ligament. Once the ligament is torn, it's not actually repairable, so we can't actually suture the ligament back together. It just doesn't heal well. So what we do is we actually augment the torn ligament with a new ligament, and we actually take a graft. So the graft is either taken from the patient's wrist or typically taken from the patient's knee, which is their hamstring tendon actually. Those are the two primary sources of the graft. There are other sources of graft. You can use an allograft, which is a donated piece of tissue, but the gold standard these days is still taking what's called an autograft, which is your own tissue. And what we do is we expose the inside of the elbow and we test the elbow and see if it is actually unstable. If the elbow is unstable, then we proceed with the surgery. And the surgery typically is one that takes about an hour and a half to do on average, and that includes the harvesting of the graft. And what we do is we actually drill tunnels through the end of the humerus bone, and then we drill tunnels through the ulna bone. And we take the graft and we actually weave the graft through the tunnels and then tension the graft, make it nice and tight, and then tie the graft together. And that essentially creates a new ligament. The rehab is about 12 months long. So in general, the patient is splinted for about a week. And then after about a week, we put them in a hinged elbow brace. And then we start them with physical therapy to start to get their range of motion back and get their strength back. By about 4 months, we let them start throwing on a very, very carefully observed interval throwing program. If they're hitters or field players, then we'll let them throw or bat at about 5 months. And then if they're pitchers, we let them start to pitch off a mound at about 9 months. And hopefully they can get back to throwing in competition at about a year. I always mention to the patients, however, that it takes another 6 months or essentially another season for patients to really get used to throwing again in a sort of a competitive arena. A lot of patients feel that they're a little bit hesitant or a little bit scared to really throw at full speed until about 6 months after they're released. And by the next season, they're usually doing very well. Typically, the success rate in these surgeries is about 88 to 92%.
Why has it seen such a rise in use?
There's a lot of media behind this surgery, and it all started with Dr. Jobe, obviously in 1974, who was able to do this pioneering work on Tommy John and fix his elbow, and he actually ended up winning 100 games after the surgery. And since that time, the knowledge and understanding of this procedure has really grown, and our ability to detect this injury has really been refined. So patients and physicians have gotten a better understanding and way to treat this injury. And a lot of patients don't want to stop playing baseball. They're not willing to give up their careers prematurely. They have aspirations of playing either at the collegiate or professional level. And when given the option to change positions or change careers or just stop playing baseball, most of the patients, given the relative success of this surgery, are opting to have the surgery. I think that's why we're doing it more and more, is because we know that this is a successful procedure. Patients are willing to commit their time and their efforts into the rehabilitation. And that's not to say that there aren't drawbacks to this. Not everyone certainly needs a Tommy John surgery, and you certainly have to weigh the risks and the benefits of this lengthy procedure and lengthy rehabilitation process.
Should parents of young athletes be concerned?
We're seeing more kids with elbow pain and kids at the lower levels of baseball play with these ulnar collateral ligament injuries because they're playing much more baseball than they ever have. In the past, we used to rely on school-related baseball activities and recreational level activities. Now the sport has become so specialized and so intensive that people are playing most of the year round, either indoors or outdoors. They have specialization coaches that are teaching mechanics throughout the year, so kids are just throwing more. They're playing on multiple teams, either the all-star traveling teams. Kids are going to different showcases to show off their baseball prowess, and in hopes of gaining scholarships or looks from different types of teams. So I think that just the level of play is really intensified over the last several years, and that relates to more stress in the elbow, more mileage, more throws, and more injuries essentially.
Are there things parents and coaches should be doing differently or looking out for?
The first thing I tell patients, and I get this question all the time, and this is a very large part of my patient population, is how much should I let my child throw, and how many months throughout the year should they throw? And I typically tell patients that they should take approximately 3 to 4 months from any type of throwing throughout the year off. I would recommend that patients and families track the amount of games that they play, track the amount of innings that they play, and if they're pitchers, track the amount of throws that they throw per game. And there are certain guidelines that we're really honing in on right now that are actually very helpful in educating patients and coaches and trainers in terms of protecting patients and making sure that they're not overthrowing. I should also mention that there are rules now in terms of what positions kids can play during the same game, such as we don't want kids to pitch and play catcher in the same game, because it just equals the amount of throws, and so it essentially doubles the amount of throws that they'll throw. So I think just keeping a close eye on the pitch count, the number of innings, number of games, and essentially how much they're playing throughout the year is really important.
Besides athletes, do other people need it?
There are different ways that you can develop ulnar collateral ligament insufficiency or a what we call medial collateral ligament insufficiency or tear. One of the ways is from trauma. And most patients who are non-overhead throwing athletes injure their elbow by either a dislocation or a hard fall where they actually traumatically tear their ulnar collateral ligament. This is a little bit different than an overhead throwing athlete, where it's usually by attrition in which they start to fail their UCL. In these patients, who are the non-throwing group, usually they're able to rehab it very well with non-operative management and be able to get back to essentially what they were doing before they had their injury. So rarely do we do this surgery on patients who are not overhead throwing athletes, because essentially you don't notice the deficit. You don't see it in real life. The only time that we essentially see this injury is when you're overhead throwing at 90 to 95 miles an hour 90 times a game. So we try to steer patients away from this surgery because it is a significant investment in patients' lives. It's about a 12-month rehabilitation period where they're going to, a lot of these patients need to get back to work and they want to be active with their families, and you just have to weigh the risk versus the benefits of the surgery, and a lot of patients do well with conservative management.